Welcome back to Core EM, the official podcast of the NYU Bellevue Emergency Medicine Residency Program. I'm Brian Gilberti, and today we're joined by one of our stellar senior residents, Dr. Reed Colling. Thanks for being on the podcast, Reed.
Thanks for having me. My high school speech and debate coach would be thrilled that I'm finally putting my skills to use.
We're truly delighted having you on the podcast with us, and there's a lot to cover today, so let's dive straight into our topic. We're set to discuss a relatively rare but undeniably formidable pathology, VTAC storm. Reed, kick us off with a faux case to set the stage and lead us into some background information about VTAC storm. What makes a storm, and who are the patients most at risk of developing this?
So you are working an overnight shift. It's relatively quiet. Things have been going pretty smoothly when overhead you get a notification that there's a cardiac eval coming to your team. You see a patient roll by. They look a little anxious, a little upset, but overall they're doing okay. You go in, you start taking your history, and they say that their ICD has shocked them 3 times tonight, and they're not quite sure what's going on. As you're getting more and more into the history, they get shocked again. The patient jumps, you jump, have to check everyone's pulse and figure out what exactly is going on. And fast forwarding, this patient is in VT storm or VTAC storm. And what that means is this person is having 3 or more sustained episodes of ventricular fibrillation, ventricular tachycardia, or in this specific case, appropriate ICD shocks in a 24-hour period. The one caveat being they may also have appropriate anti-tachycardic pacing from their ICD, but you're not going to get that at the bedside until your EP colleagues come down to the bedside. So what we think the pathophysiology of this is, to the best of our understanding, is likely a sympathetic drive or adrenergic surge that sends the heart into overdrive, causing these recurrent arrhythmias. Or there's some kind of underlying pathology, whether that's ischemia, sodium channelopathies like Brugada syndrome, or some kind of infiltrative disease, cardiac sarcoidosis, and so on.
Okay, so it's a spectrum, VTAC to VTAC storm, and it's basically when things go from bad to worse. Like you said, there are going to be a variety of causes here, and one of our primary responsibilities as emergency physicians is to swiftly identify any correctable or reversible causes. You brought up a point about adrenergic surge, and this brings up an interesting tidbit about VTAC storm, that around a quarter of the cases occur in the morning hours, specifically between 8 and 10 a.m., with a majority presenting during the day shift. So that's going to be a little bit of relief for us who are working evenings and overnights, a little bit of solace here. Now, when these patients come in, what are the symptoms that we're looking for, and which tests are you getting on them?
Absolutely. This is a pathology that can have a wide spectrum of presentations. You can have patients who are asymptomatic other than some palpitations and heart fluttering, to patients reporting syncope, all the way to cardiac arrest. And like the patient in our hypothetical case, they may have ICD shocks or have had that anti-tachycardic pacing. What you need to do is kind of differentiate, is this truly ventricular tachycardia from other potential ER presentations? A cardiac eval can be a lot of different things. In the ER, diagnostically, you're going to be looking at your EKG, which I'll let you talk about in just a minute. But other tests that are going to be really important in these patients is going to be looking at their electrolytes, particularly their potassium and magnesium, checking troponins, looking for those signs of cardiac ischemia. And then one thing that we may not always think about would be checking their thyroid hormone, because this could be thyrotoxicosis if it's really out of control.
Okay, perfect. And an important point here, ECGs are just 10 seconds of heart activity. It's really just a snapshot of the heart. It may not be something that we pick up on the initial ECG when they come in through triage, but when we do see it on the monitor, then we're calling for an EKG. And things that we're looking for are wide QRS, heart rate over 100 typically. Then we could also see fusion beats, capture beats, concordance, meaning all the QRS complex in the precordial leads are entirely positive or entirely negative, and or AV dissociation in these tracings, just to name a couple of the findings that we see with ventricular tachycardia. Now, let's say we have a pretty good idea that we're dealing with VTAC storm. The next thing we have to do is ask ourselves, is this patient stable or unstable? Now, Reed, can you talk to us about electricity's role in the management of the unstable patient?
Absolutely. This is bread and butter EM. If your patient is unstable, they're getting electricity. I feel like that was drilled into my head as an intern. So what makes a patient unstable? If they're hypotensive, if they have altered mental status, those are going to be the 2 big things. Those patients are going to get cardioverted. And one thing that's up for debate, if they already have an ICD in place, do you allow it to continue to administer what you think are appropriate shocks versus using a magnet, turning it off, and just putting them on the pads. I think that's going to be kind of institution dependent, whatever you're comfortable with. But long story short, if they're unstable, they're getting shocked.
And whenever we talk about shocking a patient who is awake, we should also talk about sedation. So tell us about the medications that we're going to be using here.
Absolutely. Sedation is going to be huge in these patients, not only just because we might be giving them electricity, but because of that catecholamine sympathetic surge that we talked about. Unfortunately, as in most scenarios, there is no ideal agent for how to sedate these patients. Etomidate or propofol can be a good option, obviously keeping in mind that potential for hypotension. Ketamine has been suggested by some, but it's going to have its drawbacks when we think about ketamine and that further sympathetic stimulation and inhibition of catecholamine uptake. It might make things a little worse.
And this is going to be another one of those situations in our field where there's going to be little room for error. Now, let's talk about medications. And I'll start off by saying that patients who have a low potassium or low magnesium, we're going to be replenishing their potassium and magnesium accordingly. For patients in torsades, then we're giving 1 to 2 grams of magnesium over 1 to 2 minutes. If we think that thyrotoxicosis is contributing to our patient's presentation, then our management just got a bit more complex, and that's going to be outside of the scope of this episode. But Reed, let's say that we're talking about our garden variety, run-of-the-mill electrical storm. Which meds are we giving?
First medication we're reaching for, we're going into our toolbox, is going to be amiodarone, our good old class 3 antiarrhythmic. This is what's been most studied in VT Storm. It's what our cardiology colleagues are going to most recommend. So giving them 150 milligram IV load over 10 minutes, followed by an infusion, first thing you should do. If we're looking at refractory, amiodarone's not working, you can add on further antiarrhythmics. You might consider doing lidocaine, you consider procainamide, and then we're talking about beta blockers as well. In the ED, I think we're most comfortable with esmolol, we're most comfortable with metoprolol pushes, but in this specific scenario, the American Heart Association actually recommends propranolol, 40 milligrams, and that has demonstrated the most effective early cessation of ventricular arrhythmias, possibly due to it being non-selective, inhibiting both beta-1 and beta-2.
Very good. And this doesn't necessarily align with our traditional approaches for ventricular tachycardia. So I'm glad that we're addressing it here. And as you mentioned, we typically lean towards procainamide to treat ventricular tachycardia, giving a nod to the Procameo trial. However, for electrical storm, amiodarone is more extensively studied. And on top of that, emphasizing your point, when dealing with unstable patients who need beta blockers, I'm thinking esmolol or metoprolol to temper their cardiac activity. Propranolol, I have to say, doesn't usually come to mind in these situations, but in this context, in VTAC storm, it does have a significant role and a demonstrated benefit for these patients. Okay, let's move on to discuss the next steps for these patients.
Absolutely. These patients are almost assuredly ending up in your cardiac intensive care unit, or if that's not available, definitely the medical ICU. But there are some other interventions they still might need. If you find out that this event was precipitated by ischemia, they might be going to the cath lab first for stenting or balloon angioplasty. Refractory cases might end up needing intra-aortic balloon pump for further cardiac support. Patients have even ended up on ECMO in the past. And then kind of a last-ditch effort, you might consider a stellate ganglion block to really shut down the sympathetic nervous system.
A lot of Herculean efforts to save these patients who are very, very sick. Let's take a step back and go over some take-home points here. VTAC storm has multiple definitions, but one of the most commonly used is 3 or more sustained episodes of VFib, VTAC, or appropriate ICD shock in a 24-hour period. The presentation can be varied. The range can span from palpitations to hemodynamic instability. And your first EKG may not show VTAC. It may be a diagnosis that we make while the patient's on a cardiac monitor or when EP interrogates the device. Looking for typical signs of VTAC on ECG are going to be wide QRS, usually a rate over 100, and then also keep your eye out for fusion beats, capture beats, AV dissociation, concordance, just to name a couple of those signs that we look for. Cardiovert if there is evidence of hemodynamic instability. And when choosing an agent for sedation, keep in mind that these patients are already in an increased adrenergic state, and ketamine could worsen the cardiac irritability. Medications that we typically reach for to temper the storm are amiodarone and propranolol. Finally, get our cardiology colleagues involved early, especially since treatment can go beyond just medications here. Okay, that's going to do it for this episode. Dr. Colling, thanks for being here and taking time out of your busy schedule and sharing your speech talent on our podcast. We look forward to more episodes with you.
Thank you for having me.